This condition called hypoglycemia associated autonomic failure, HAAF, should be recognized by all of us. There is a relative or absolute insulin excess. It occurs in diabetics. Defective glucose counter-regulation leading to compromised physiological defense. In the normal individuals, whenever there is hypoglycemia, immediately insulin is suppressed, glucagon is increased, epinephrine is increased, noradrenaline is increased, cortisol comes into play, growth hormone is increased, the urge to eat food is stimulated. These are the counter-regulatory mechanisms. If they are reduced, if they are compromised, then there is defective glucose regulation and hypoglycemia occurs. Hypoglycemia unawareness, that means recurrent episodes of hypoglycemia. In the first episode, patient feels a full-blown symptoms of tachycardia, the palpitation, sweating, anxiety, confusion and all that. As he gets recurrent episodes, he gets adjusted to the symptoms, he is not aware, and the autonomic symptoms and the neuroglycopenic symptoms do not manifest, particularly the autonomic symptoms or the adrenergic symptoms do not manifest as clearly as they occur in the first episode. This leads to what is called hypoglycemia unawareness, so much so even if the blood sugar is around 40 or 35, patient does not have the symptoms, so much so he will not seek help. This leads to compromised behavioral defenses. These patients who have HAAF have six-fold increase in the risk of hypoglycemia. Patients with hypoglycemia unawareness are 6 times increased risk of developing hypoglycemia. Patients who have full-blown HAAF, that is the hypoglycemia associated autonomic failure, they have 25 times increased risk of severe hypoglycemia. Every diabetic patient must be taught about hypoglycemia, its manifestations, and how to immediately counter it at the home itself before they really seek help. So this chart in a way explains the same concepts which we have looked at in the previous slide. Hypoglycemia associated autonomic failure, there is insulin deficiency in diabetics, we know, and these insulin deficient diabetics, they will not have a normal insulin reduction whenever there is hypoglycemia and there is no stimulation of glucagon, there is antecedent history of hypoglycemia, or their sleep adds to the picture, the difficulty of the picture, reduced sympathoadrenal response to hypoglycemia. Normally there must be sympathoadrenal discharge, epinephrine, norepinephrine should be stimulated, that does not occur, and that leads to reduced sympathetic neural responses or reduced epinephrine response. Decreased sympathetic neural response lead to hypoglycemia unawareness, reduced epinephrine adrenergic drive leads to defective glucose counter-regulation. So hypoglycemia unawareness, defective glucose counter-regulation together produce recurrent hypoglycemia, and that is what is called hypoglycemia associated autonomic failure. Of course, antecedent exercise and sleep will add further fuel to the fire and produce a situation of HAAF or recurrent hypoglycemia in these patients. Reactive hypoglycemia. What is reactive hypoglycemia? Unlike the hypoglycemia in diabetics which occurs in the fasting state, reactive hypoglycemia occurs in the postprandial state, 2 to 3 hours after the meal, exclusively in the postprandial state. Why a patient should have hypoglycemia after having a meal? After all, the blood sugar should be more, isn't it, after taking food? But in reactive hypoglycemia, what happens is, this is also called alimentary hypoglycemia, early hyperinsulinism after food. Normally, food triggers the release of insulin, and this triggering of insulin after food occurs very early because of increase in the GLP, glucagon-like peptide 1, and it's a suppression of glucagon. So glucagon-like peptide, not only it stimulates the insulin, it suppresses the glucagon. Okay, when the glucagon is suppressed and the insulin is overproduced, before the food actually builds up the glucose levels, there is excess insulin present, in the system, and there is no glucagon to counter-regulate it. So much so hypoglycemia is experienced. Autoantibodies to insulin also are a cause and they potentiate insulin action. Unlike other antibodies which attack the hormone, here these antibodies will potentiate the action of insulin, because these antibodies are to the insulin receptors, and these antibodies which stimulate the insulin receptors attract the insulin onto the receptors, and insulin's action is potentiated and hypoglycemia is precipitated. So how to counter reactive hypoglycemia? Give them frequent small feeds rather than giving a big meal, because these frequent small feeds will not stimulate the immediate insulin release to that extent, and avoid simple sugars which will suddenly produce a spike in the blood, and give them complex carbohydrates. High protein diet, complex carbohydrates, simple small feeds are useful in countering reactive hypoglycemia. Of course, drugs that prevent the absorption of glucose, like alpha glucosidase inhibitors like Acarbose, can also be tried in these patients. Fictitious hypoglycemia usually occurs in a diabetic patient, but can occur in any type of person. Sometimes in non-diabetic persons also. Surreptitious or malicious administration of insulin or oral hypoglycemic agents. Insulin or OHC is inadvertently administered or taken or willfully taken by the patient for suicidal purpose. Diabetic patients, doctors, healthcare workers are the most prone for this particular fictitious hypoglycemia, because these are the ones who have access to the hypoglycemic medications. Suicidal attempts by insulin use are known in literature. Glucose monitors are not the accurate ones to measure low sugar ranges. Remember, glucose monitors are erroneous, particularly if the blood sugar is less than 60 or less than 70, the monitor may not show the correct value. So then what to do? Take a blood sample and also use the monitor. Immediately make your treatment decisions based on the monitor value, but get the lab values as soon as possible, so that your diagnosis of hypoglycemia it will be confirmed by the lab sugar. What is pseudo-hypoglycemia? Pseudo-hypoglycemia means it's not a case of hypoglycemia, but there is an error somewhere in the test and hypoglycemia is reported, either because of the blood glucose monitor, or due to the laboratory errors, or the non-use of fluoride while transporting, because without fluoride the blood sugar levels drop very fast in the sample, or time delay in the glucose testing after the sampling. Suppose you take the blood sugar sample in the morning at 8 o'clock and the lab analyzes evening at 5 o'clock, the lab result will be much lower than what it is normal. Blood glucose instead of plasma glucose. Never do a blood glucose. Always plasma glucose should be measured, because the blood contains the formed elements, the RBC, the WBC and of course the platelets, which metabolize the glucose that is present in the sample, and the sugar values drop down. This happens further when there is erythrocytosis, when there is leukocytosis, when there is thrombocytosis, when there is sepsis. In all these conditions, the blood sugar levels in the sample drastically come down, and there could be a result of hypoglycemia, but the patient may not actually have hypoglycemia. So remember always to draw a sample of blood before giving treatment for hypoglycemia with either oral or parenteral glucose, and also of course you can use the bedside monitor to immediately know what is happening, so that the treatment need not wait for the lab report to come. So pseudo-hypoglycemia is a problem which we require to remember, and whenever we have a patient who doesn't have symptoms or signs of hypoglycemia and whose blood sugar levels are reported low, and his symptoms do not improve with treatment of hypoglycemia.